Our third speaker, yet another migrant from Europe, well supplied with them this morning, is Dr. Alex Lehn, who heads the Movement Disorders and Deep Brain Stimulation Services, which I think is a great title, at the Mater Hospital in Brisbane, and runs a dedicated clinic for functional neurological disorders at that hospital. Please welcome Alex. Thank you very much indeed. Welcome.
Hi everybody, and thanks very much for having me. I know we're very precious for time, so I'll keep the introduction part short. I'm very excited about being here, and thank you so much for the first two talks. It was really nice to hear that. This talk is more of just a few practical points I wanted to make. Hopefully they are of value for you as well. I can't hide the fact that I am a neurologist, but hopefully this is also valuable for non-neurologists. A few things I wanted to get straight first. Does the label matter? I have a pet hate for the term medically unexplained syndrome, as I have many other pet hates in the area. I'm a very positive person otherwise, but these things really kind of get me up. I think what we have to realize, if we use certain terminology, if you mean to or not, you deliver a certain package of information. You might not mean bad with that, but if you use many of these terms you can see up there, which are all of them still commonly in use, you deliver a package. So if you tell someone, oh, what you have is non-organic weakness, well, you tell them what it not is, but you don't tell them what it is. If you tell someone, oh, what you have is pseudo-seizures, you might not mean bad, but for the vast majority of patients, they're like, great, so you're telling me I'm faking it, really. If you tell someone what you have is medically unexplained, the patient will walk out and think, so you actually have no idea really what's wrong with me. I like the term functional neurological disorder or functional symptoms in general. It makes sense for me. I think it makes sense for most patients. If you just think that one word, that one sentence, functional neurological disorder, your central nervous system is not irreparably damaged, but intermittently not functioning properly anymore. For most people, they'd be like, well, I guess kind of makes sense, and that's probably why the scans are normal. Most people find it acceptable and find it makes sense, and I do so as well. This is not just me making this up. There's a beautiful study from the early 2000s, actually done in orthopedic outpatients, where they went to outpatients and just said, look, so if you had weakness down one side and the doctors gave you one of these diagnoses down there, what do you think the doctor is really telling you? And you can see if you do things like, oh, your weakness is psychosomatic or medically unexplained, a lot of the patients, if you want to or not, are thinking really what he's telling me is, I'm just putting it on, I'm mad, or I'm just imagining my symptoms. What they also did afterwards is they calculated the number needed to offend. You might know the number needed to treat that we use for studies. So the number needed to offend is how many patients do you have to deliver a certain diagnosis to until one of them is pissed off with you. That number is literally 1 for all those things on the left-hand side. The term functional neurological disorders not only explains what's actually happening, but also is acceptable for patients. So really, that's what we use in our clinic, in our service. It makes sense for me. And I come back to at the very end, I think consistent language across the team is really, really important for those patients. A few points I wanted to make, it's just in general when dealing with those patients, because let's face it, we all struggle with them. These are often tricky patients. We all been there in busy outpatient clinics, already running an hour late, and you get those heart-sinking patients coming in with like 2 piles of old scans like that and handwritten notes on 3 pages with all the symptoms they have, and you think, oh, how am I going to deal with that? They can be very time-consuming. And there are things we're worried about. We're worried about getting diagnoses wrong. We're worried about missing weird and wonderful things and nasty things. And none of us, as David told you beforehand, has learned how to deal with it, how to explain the symptoms to patients. And we struggle with that. And let's face it, we're all nice people. We want people to like us, and we're worried about those patients being angry about us. On top of that, patients often come to us with a lot of preloaded bad experiences. They often have been quite scarred by previous doctor experiences they had. They often had not a chance to explain all the symptoms they have. They often feel just dismissed and palmed off by previous doctors and by other specialists. And very often, quite harmful, I think, have this perception that, oh, whatever they come in with, the doctor is just interested in previous psychological stresses and previous trauma without actually listening to the patients. I think a big issue is that we tend not to listen to patients to see what do they think what's going on. And it might be something quite what you think ridiculous, like Lyme disease. But that might be very important for a patient, and I think we're going to have to address that better. And lastly, patients often don't feel they have enough time with the doctor. So what can we do about that? And absolutely, GP practice, 8 minutes per patient, I think impossible. Even in a general neurology or other outpatient clinic, very, very hard. But I think we should accept that just taking the history, that's where the treatment starts for all the patients, but particularly for functional patients. There's a real therapeutic element in taking history. And these are a few things I learned that certainly work for me, that I think make a real difference to get that start right and work on this patient-doctor relationship. I really try to drain symptoms dry in my patients. When I see a patient who I think will end up having a diagnosis of a functional disorder, I even make a point of going through various symptoms and make a list with them. And that list might be at the end 10, 15, 20 different symptoms, but I write them down once, so we make sure we really captured everything well. If you can get comfortable in that area, being able to be comfortable to ask about dissociation, I think is really helpful. This is something very weird and very uncomfortable for patients to talk about. Most doctors don't feel comfy in that area either. I think that really helps. I make a point of asking my patients what they think is going wrong and what should be done about it, and I make a point of readdressing that at the end of my first session as well. I would suggest, unless you're someone like Kasia who is really comfortable in that area and you have time as well, at the start, go easy on psychological questions. For me, in my decision-making process for the diagnosis, the psychological background actually doesn't make a difference. I'm well aware of the risk factors in the data, but the basis of the diagnosis should not be based on that. And you can get in real trouble if you have a patient then already running late, and you're like, oh, have you had any trauma in your childhood? And the patient's like, oh my God, I cannot believe you asked it. Yes, I've been abused as a child. I've never told it to any doctor. And you're like, I'm running an hour behind, so we might have to. Doesn't work. Does not work at all. So I think we have to be careful with these things unless you are a psychologist, psychiatrist, or someone else who's come from that area. I know we don't have time, but I think if we can, we shouldn't rush these kind of patients, at least to a degree. I think what we have to move on in medicine is this, every new patient gets half an hour and every review patient gets 15 minutes. That's just how it is. If you look at our surgical colleagues, they're quite aware that some surgeries take a lot of time and some surgeries are very quick. And I think we should accept it to a degree as well and try to give these patients a bit more time. I think it's very worthwhile. Just a few slides I wanted to show you. How do we make the diagnosis of functional neurological disorders? Contrary to common belief, this is not a diagnosis of exclusion. And please walk out from here today and realize that this is not diagnosed because all scans are normal or because things look weird. In my movement disorder clinic, I can show you lots of really weird looking things that are definitely organic disorders. So the basis of diagnosis of FND is based on two factors, inconsistency and incongruity. So every patient I see at the end, I get down to, is this presentation inconsistent or incongruous? So inconsistency also means internal inconsistency. There might, for example, be a tremor that is there one moment, and if you distract it away, it's gone, or weakness that is distractible or variable. And incongruity also means incongruity with recognized neurological disease. To be comfortable with that, you kind of have to know what are recognized neurological presentations of certain disorders. And again, with that, just weird doesn't cut it. We really want to diagnose FND based on hard, positive signs. You might have heard of Hoover's sign, and I would love to show you a video, maybe another time, I don't have time today, but I'll just show you a video for two features, distractibility and entrainment. So what you see in a second is a patient in his 50s with a functional tremor. You can see a really unpleasant bilateral upper limb tremor. You might hear that they try to do serial sevens with him, just try to distract him, which doesn't really make a difference. And then they ask him to copy movements with one side of the limb. And you can see as he really focuses on that, first actually the tremor stops, but then also entrains to a different frequency. So really focus on that, tremor stops on the other side. And as soon as he stops with it, bam, tremor back again. These are called ballistic movements. He's asked to copy movements on the other side again. With every ballistic, every fast movement, tremor stops, stops, and back again. Stops, and back again. Really simple stuff, like everyone can learn it. There's no rocket science to it. These two features, no other tremor does that. No essential tremor, no Parkinson's tremor, no other tremor does it apart from functional tremors. In regards to treatment, I don't want to devalue psychologists. Our psychologists do an amazing job. The point I tried to make is we all have to do our part as well. So I'm not sure if in other states you've got the same thing. Like in Queensland, we can send via GP patients to psychologists, I think for 6 or 10 sessions, they're a bit cheaper. That doesn't cut it. So just you got something weird, off you go, do the 6 sessions. Doesn't work like that. We all have to do our part for CBT. If you have a patient that comes in thinking they might have MS or Lyme disease, and they walk out realizing they have actually a functional neurological disorder, this is cognitive therapy. If they change their behavior based on this, you have done your part for cognitive behavioral therapy. We all have to work together for these patients. Pharmacotherapy, completely overrated, so just a few happy pills will not cut it. I probably would have started 2 handfuls of patients on antidepressants over the last 2 years amongst a few hundred. No doubt, good psychological therapy and good physiotherapy, often combined, really, really important. Generic services don't do well with that, but as Kasia told you before, and can make a massive difference for these kind of patients. One question we always get is, well, why did I get it? What happened? And that gets really uncomfortable for all of us. Can I suggest for that as well, if you can, in general, focus more on the mechanisms rather than why things happened. If you think about it, certainly in my practice, that's actually what I do with most other patients as well. Very, very rarely do I discuss with a patient why they got Parkinson's disease. Well, I don't know anyway. Or why they got migraines. I don't know either. I know the mechanisms, what happens, but I don't know why they got them. Generally for us, the whole software-hardware analogy works really well. Your hardware is intact, the software is not working. The way the brain communicates with the body is not working. I think for most patients, that makes sense and works quite well. Those general explanations work reasonably well for most patients. And I think this whole Freudian, nothing wrong with Sigmund Freud, smart man, this whole Freudian thing for lots of patients is actually not very helpful, at least in first sessions. So what can you do as a non-neurologist or as a neurologist who's not comfortable making those diagnoses to help with the treatment of these kind of patients? I think observing and sharing symptoms and changes of symptoms can really help. So in patients, for example, with functional weakness, who you then in a non-judgmental way can pick up, oh, can you see when you tried, you couldn't move, but actually when you lifted up the leg, you actually could get your leg up? Or could you see actually your tremor when we talked about something else actually really went away when you got distracted? Really, really helpful to pick these kind of things up. Kasia told you beforehand a few of the things we often teach our patients as well. Grounding techniques, breathing techniques, PMR, none of that rocket science, all simple stuff. If you can be comfortable with those things and teach your nursing staff as well to be comfortable with those things and reinforce that when these patients are on the ward, I think that's really helpful. A lot of the work we do is kind of reinforcing and working on internal locus of control. That's something really helpful if you can do that as well. I think overall, we have to learn as a group of health professionals to communicate better. That's both with patients as well as with other team members. I regularly pull people up on certain things and they probably laugh about me in the background. Not that rarely do I walk into rooms and people are like, oh, Alex is walking in. We're not allowed to say those things anymore. And they probably laugh about me behind me, but I still think we can slowly change approaches. And I think us as doctors, we really have to give a good example for the rest of your colleagues as well. I think it really helps if you can familiarize yourself with the approach your colleagues have. Same approach, really important. Same language, really important. Learn to trust your colleagues. I know exactly what my physios do with my patients. They know exactly what I explained to them beforehand. I think that's one of the steps that make a big difference for treatment. And with this, I thank you very much for your attention.